Well, good evening, everyone. I know we'll still have some people join, but my name is Paige Harrington. I work with Vets Pets here in North Carolina, and I am very, very happy tonight to be able to introduce Dr. Heather Roden, who we met through the ER circuit, and I am very happy that she was able to join us this evening. Dr. Heather Roden is a quick-witted, kind-hearted, and deeply knowledgeable veterinarian that I'm really honored to be able to also call my friend. With a bachelor's from the University of Nebraska, a master's in ecological parasitology from Oklahoma State, a veterinary degree from Oklahoma State, and now working on an MBA from NC State, Dr. Roden can definitely hold her own with the best of them. After working GP and ER in Oklahoma and then Texas, Dr. Roden moved to North Carolina in the fall of 2020 to join the ER department at NC State. As an emergency medicine clinical instructor there, Dr. Roden works to educate veterinary students about ER medicine while also managing incoming cases and speaking to folks like us on the phone in need of guidance, often freaking out, wondering what we should do. And then on her LinkedIn page, I was stalking her a little bit the other day. She has that she bridges the gap between emergency and specialty medicine with emotional intelligence. And having worked side by side with her, that is definitely a very good description of how she's able to approach her cases. Having worked with her, I know she approaches each case with what's this client able to do and what are we able to do, and let's make a plan. And it's been really nice getting to know her, and I'm happy that she is here tonight to be able to present general practice when the ER is full and they are headed to you. Things to keep and note as we go through: you will be receiving your CE certificate emailed to you in the next few days. Along with that, Dr. Roden has put together a really great handout of multiple different drug doses and routes. So do not feel like you need to be frantically writing some of these things down. You will be able to get them in an amazing handout that you'll have as a great reference going forth. So Dr. Roden, thank you so much for being here. And if anyone has questions, please enter them into the chat. Depending on the question and the timing, I will either interrupt Dr. Roden or I'll save them for the Q&A at the end. There's not a go back and forth conversation, but we can do it all through the chat. And Dr. Roden, please take it away.
Awesome. All right, let's see if I can get this to work. There we go. So thank you guys for all showing up tonight. I know you probably all had long work days, and thank you, Paige, for the introduction. I want to start out with a poll, so there will be a poll popping up for you guys. Poll question number 1, how annoyed are you when a doctor from a fancy university tells you how to do your job? Are you A, not annoyed? University professors are so smart and always helpful. Mildly annoyed? Maybe she'll have some tips I can actually use in my practice. C, moderately annoyed. This lady has no idea how I practice in the real world, but I'll stay because my boss said I must. Or D, severely annoyed. I plan to mute this lecture. I just need the CE credits. So I'll give you guys a moment to vote. Please be honest and don't blow smoke up my behind, please. All right. Not annoyed at all. So you guys are all wrong. University professors are not all so smart and we're not always helpful. But thank you for that vote of confidence. Those who voted anything else, thank you for your honesty. I am hopeful that tonight I'll be able to actually give you guys some tips to use in practice. So I'll get started. Paige did a great job introducing me, but I want to share just a little bit more of the details. So I was born and raised in a small town in Nebraska. It's a tiny town called Bradshaw, and these pictures on the left are actually the main street of Bradshaw and then the cornfields surrounding the town. The picture on the top right is the only vet clinic in the county, which was about 15 minutes away from my home. It was all I knew of veterinary medicine till I was about 18, and I just assumed that all veterinary practices were small, unmarked buildings that took care of pets during the day, and then if you had an emergency at night, you would go into that hospital. And even if you were 8 years old, you would get to help with the emergency. What I didn't realize at that time was that was because the vet didn't have anyone to help after hours. So that was my introduction to veterinary medicine and how I viewed veterinary medicine most of my life. I then went on to Oklahoma State University, where we didn't have much of a emergency department. And after graduation from Oklahoma State University, I did a year-long rotating internship at Texas A&M. And that's where I got slapped in the face with the reality of emergency medicine. We were seeing 20 to 60 cases every single day, and we were left alone as interns overnight. And I had no idea what I was doing. I was terrified. And by the end of the year, I hated emergency medicine. And I swore to the universe I would never practice emergency medicine again. So I started my journey into becoming a general practitioner, and that lasted 8 months for me. I was frustrated that I could never fix dogs that had skin disease. I had so much fear and anxiety around spaying dogs and pulling teeth and doing dentals, and ultimately it left me very depressed. Luckily, I decided to pick up some ER shifts and realized I liked large abdominal incisions, instant gratification, and the adrenaline rush that accompanies pending failure. So after all, I did find my place. Turns out I also like mechanical ventilation, trauma CTs, and teaching, which led me to NC State ultimately. And if I was asked to sum up my teaching philosophy, it is this: emergency medicine can be scary, but anyone can learn to practice emergency medicine if we make it practical and accessible. So in my experience, the only thing more frightening than an emergency is not having the tools to manage it. So I want a little bit of audience participation here. Go ahead and put your answers into the chat. For you, what veterinary emergency cases scare you the most and why? And Paige will share these answers with me.
Cardiac.
Yeah. Okay.
Yeah.
Those are terrifying. Agree.
Pneumorabs, pneumothorax, DKA, Addisonian endocrine type cases, polytrauma, hit by car, DKA exclamation point.
Excellent. Well, there's definitely some on the list that we're going to talk about tonight. There's some of them in there that we're not going to talk about tonight, but I'm happy to have you guys contact me after this and we can talk about what might help you get through those a little bit easier if I don't touch on your topic. But I think I heard respiratory in there, and that's where we'll start tonight. But because I'm getting my MBA, and I know that many of you guys are practitioners that also manage your hospital, I want to give you guys a little bit of analysis of emergency medicine. And you're going to see this slide pop up over and over. But this is, in general, my overall analysis of emergencies in veterinary practice. So from a psychological standpoint, many practitioners feel self-doubt, anxiety, and fear. They also feel isolated. You may be the only hospital in 20 miles or 100 miles, and you may have a history of negative outcomes for your patients. So that's a big psychological burden to bear. Physically, you probably don't have enough staff in general, and then you definitely don't have enough staff when emergencies come in the door. You may lack the ideal equipment or supplies for emergencies. And we can't forget that there are physical manifestations of that psychological stress. So not eating right, not sleeping right, not taking care of yourself will also add to that physical stress of emergencies. The educational component of emergencies, I'm glad that you guys are all here tonight, but you may lack exposure to emergencies and you may lack practice at doing emergencies that have positive outcomes, therefore leading back to more psychological and physical stress. Financially, here's the one category I can say that some things might be positive. So we know that emergencies can increase your revenue. However, they can have pretty high costs to your clinic in things like supplies, time, and staff. And the worst category of all is time. So you have to have time to manage the emergency, you have to take time to clean up after the emergency, and then you have to reschedule all of your appointments. So of this analysis, we can give one tiny little star out of 5 to emergencies in a general practice setting. So do not recommend doing emergencies in general practice. However, we all found out during the pandemic that ERs were filling up, and despite our best efforts to keep emergencies out of the general practice setting, they were headed to you. So today, what I want to cover is some of those things that you guys talked about in the chat. And we're going to talk about respiratory emergencies, hemoabdomens, GDVs, seizures, and then what I like to call the oh shit kit. And then I'm going to give you some of my favorite resources that will hopefully help you in years to come. So my overall goal is to sharpen the tools that you guys already have so that you can make the best plan possible given your unique set of constraints. Not everything in this presentation will work for every hospital, so I want you guys to pick and choose what works for you, and definitely ask other questions if you think something kind of might work, but not specifically for your situation. At the end of this, I hope that you can all give emergencies 5 very small stars out of 5 in your practice. So the first thing we're going to do is we're going to take a big breath. We all know that your body cannot be stressed and relaxed at the same time, no matter how hard we try to convince ourselves, I'm fine, this is fine, I'm okay. Take a breath and relax for one moment. We all make better decisions when we're relaxed. So this is the number one thing that I teach anybody learning emergency medicine, is to take a big breath. And with that, we're going to start in on respiratory emergencies. So I tried to break respiratory emergencies down into very simplistic way of thinking about how to manage them. So the first thing is oxygenate. Second thing, sedate. Third thing, took some liberties with this one, radiate. Really what I mean is get some images. And then the fourth thing is, when do we intubate? So we'll go through each one of these. So this would be what we call the gold standard of oxygenation therapy for our patients. This is a beautiful Snyder cage. We all wish that we had one or 5 in our hospital, but the reality is that they're incredibly expensive, and the wait time to get even a refurbished one is at least 6 months at this point in time. So if you have one that's in proper working condition, excellent, I'm happy for you. But if you don't, there's so many more ways to oxygenate your patients. One of the things that we do routinely at NC State is put nasal cannulas in large and small dogs. And the measurements that we take for these is actually to put the tip of a red rubber catheter introduced into the nose and get it to approximately the oral pharynx. And you do that by measuring to the ramus of the mandible. You typically only have to put in one red rubber in one side of the nose. And this provides oxygen to that oral pharynx pretty directly. And doing so can make it so that you can have decreased oxygen flow rates, and you're not wasting all of that dead space if you only put it in a few inches into the nasal cavity. Below that is one of my favorite ways to get oxygen to a patient if you don't have an oxygen cage and maybe you don't have any red rubbers that'll fit in the nose, or if the patient simply won't sit still long enough for a red rubber catheter in the nose, is to try to provide them a little bit of extra oxygen by giving them a hood. So they do make these that are pre-made with little zippers and things like that. But really all you need is a plastic e-collar, some saran wrap, tape, and then an oxygen line, as you can see down here in the bottom, plumbed in, tucked in around the neck, and then taped inside the collar. As you see here at the top, we actually leave a little bit of space open for CO2 to escape from this contraption. In the middle, this is just one of the many representations of companies that have now come out with portable oxygen. So these are actually very small canisters, no bigger than a water bottle, that come with a little regulator, tubing, and various sizes of masks. They can also be used with these pop-up tents. So this can provide a very small footprint in your hospital for oxygen supplementation for your patients, and potentially at a cheaper cost to you. In some cases, I've seen hospitals actually send these with owners when they need to transport to another hospital. Oxygen concentrators are also a really great way to get oxygen into your hospital if you don't have the availability of larger tanks or oxygen plumbed through the hospital. And just of note, this top right picture is a picture of the most well-behaved dog in the universe. Most dogs don't like to have that plastic or rubber constriction around their face. So we typically actually take that rubber part off and just hold the oxygen mask up to the face as much as the patient will allow. So moving on to sedation. So any patient that is looking at you like this is actually screaming for you to sedate them. Many patients who come in respiratory distress are incredibly fragile, and they can actually pass away quickly from just some handling. A lot of people think, oh my gosh, we need to sedate them, we need to get it IV, that's going to work the fastest. But in my experience, getting some sedatives intra-animal, usually IM, works the best, and then let them sit in oxygen and try to relax as much as they can. I know from experience that if the patient passes away with even the mildest amount of restraint, there was probably not a whole lot more than you could have done. So I typically start with butorphanol, 0.1 to 0.3 mg per kg IM. I put them in oxygen, and I stand outside of that cage and wring my hands until I have another plan. The next step is radiate, or get some images. If you're taking radiographs, I urge you to always get orthogonal views. That way we can see the pulmonary pathology in all sections of the chest, not just a VD, not just a lateral. In many cases, you may not be able to get all of the images at once. So I urge you to take the patient out, see what they'll tolerate. Maybe you get one right lateral, and you have to put them back in oxygen. Maybe you can only get a DV and not a VD. That's okay. Give your patients time. If you do have an ultrasound in your practice, this is actually a really easy way to image your patients and get a little bit more information about what's going on to cause this respiratory distress. Now, I'm not going to talk about point of care ultrasound, fast scan, vet blue, whatever you may want to call it tonight, except to say that if you do have an ultrasound in your hospital and you don't know how to use it, I recommend taking some of these trainings or contacting another hospital that might be able to send someone out and chat with you guys about how to use this a little bit better. And then also know that this is a great modality for your patients that are in the oxygen cage. They can just sit there getting oxygen pumped to them, and they don't have to lay in awkward positions while you image them, and you can get quite a bit of information. So once we have our images, then we have to ask ourselves, well, do I need to medicate this patient, or is there something going on with these lungs where I need to reinflate the lungs so that they can breathe better? So this first set of images are patients that would require oxygenation and then medication. So on the left, we have a very typical lateral projection of a patient who is in heart failure. We've got this enlarged heart and then pulmonary edema. So for this patient, I would say even one lateral radiograph might give you enough information to start your process of, you've already got some oxygen in them, you maybe already have some torb on board, you've got one x-ray. Now you have enough evidence that this patient will probably benefit from some Lasix. So giving them some Lasix, some more torb if they need it, and some time is the best recipe in this case. On the right, we've got a patient who we snapped VD and found that they have an alveolar pattern in the right middle lung lobe consistent with aspiration pneumonia. This patient needs oxygenation, sedation, and medication, IV fluids, antibiotics. If you can't get an IV in them safely, you could do injectable antibiotics sub-Q intramuscularly until a time where they're feeling better enough or sedate enough to be able to get IV fluids into them. The next part, this is a little bit scarier. So what happens when you need to reinflate, especially when you get one of these radiographs and you don't have an ultrasound? So just to review, the radiograph on the left is a typical image of a dog with a pneumothorax. These guys are going to come in respiratory distress and may not have lung sounds in any of their fields that you can really hear. And on the right, this patient has quite a bit of pleural effusion down ventrally in the thorax, and you can see the lobar signs. So what do I do if I don't have an ultrasound? Well, I think you guys are good enough at auscultation to kind of get a sense of where can I not hear lung sounds and where might be a safe place to tap. The other rule of thumb is to use the xiphoid to guide you. I used to count rib spaces and get really nervous, and then I learned that the xiphoid on most dogs actually falls somewhere between the 7th and 9th intercostal space, which just happens to be the most perfect place to tap a chest. Now, if you do have a dog with a pneumothorax, such as the one on the left, what we recommend is that you lay the patient into a lateral recumbency, and then you introduce your needle to tap that chest at the highest point on the chest. That's where the air is going to be trapped. Now, I do recommend auscultating over that area before you tap, because if a dog or a cat only has a unilateral pneumothorax, then you may actually be puncturing into lung that is aerating. In the event that you have pleural effusion, the recommendation is to tap in the ventral 1/3 of the chest, just above the xiphoid, so the 7th to 9th intercostal space. In both of these procedures, I typically recommend that you clip, clean, and introduce your needle sterilely in these situations, though in some cases I have not followed my own directions when a patient might be gasping for air, specifically with the pneumothoraces. So what happens when you have muffled heart sounds on your exam? The patient's tachypnic, dyspneic, they have thready to non-palpable pulses, pale mucous membranes, and they may or may not have a fluid wave. You get them some oxygen, you get them sedated, you snap a right lateral radiograph, and you see this monstrosity. So the two major differentials for this type of patient would be DCM or cardiac tamponade. And the major determiner for me, if I don't have an ultrasound, would be muffled or absent heart sounds on auscultation. Typically, patients with DCM are going to have auscultable heartbeats, and they may actually have arrhythmias that you can hear. A patient who has pericardial effusion and has cardiac tamponade causing all of those other symptoms likely is going to have, at minimum, muffled heart sounds and maybe even heart sounds that you can't hear. So if you are lucky enough to have an ultrasound, what you can do is look for pericardial effusion. So this is a typical view of the chest in a dog that has pericardial effusion. So here is the left ventricle, here is the right ventricle, and the PE or black around the heart is pericardial effusion. In this case, the effusion is enough to actually cause pressure collapsing the right side of the heart. And that is what leads us to having decreased preload and putting these patients into a state of cardiac tamponade. In these cases, most of these patients are going to pass away pretty quickly if you don't relieve the pressure from around the heart and increase their preload. So while you are pulling up your britches, taking your deep breaths, shaving that chest, and getting all of the courage that you've ever needed to tap the pericardium, you can be putting in an IV catheter and giving these patients 5 to 10 mils per kilo bolus of IV fluids. Now, what if I don't have an ultrasound, Dr. Roden? Well, I hate to say it, but you can do a blind pericardiocentesis. So if you have an ultrasound, it's a much more relaxed situation, but still should be scary because you're putting a needle near the heart. But you can do a blind pericardiocentesis. Again, One of my differentials for a patient that has radiographs that looks like this is DCM. So you have to realize you may be taking a risk of actually just poking the heart. But if you're confident that this patient is in tamponade, my recommendation would be to either place the patient in sternal recumbency or left lateral. You want to go on the right side of the chest in the cardiac notch. You'll go between the 4th and 5th intercostal spaces. And if you don't have time to count, lay the patient there, kind of pull their elbow back a little bit, and that is right where you should be. For this procedure, I use one of two things. I oftentimes use 18 or 16 gauge over the needle catheters. Sometimes we'll use catheters that actually have multiple fenestrations in them. Or in smaller patients, I have used butterfly catheters. Now, the risk you run with a butterfly catheter is that it's not as flimsy and you do run a higher risk of puncturing the cardiac muscle. Now, my recommendation is to always put ECG monitors on these patients, but if you don't have that in your hospital, have somebody there monitoring pulse quality, respiratory rate, providing them oxygen, and warning these owners that you're doing this at a very high risk. If you do have ECGs on your patient during these procedures, always have lidocaine at hand, because many times as your catheter starts brushing up against the heart, you will have some VPCs. In that case, typically I start to remove my catheter and give them lidocaine. The other kind of plus that often happens is when you introduce your catheter or your butterfly needle, oftentimes it will tear the pericardium and that fluid just goes rushing out into the chest. In most cases, those patients feel quite a bit better. And just a reminder, pericardiocentesis should scare you. It still scares me. It scares a lot of our cardiologists until they get into the rhythm of doing it. If you need guidance on these, please feel free to call NC State and somebody will walk you through it while you're doing it. But please don't send patients away or to another facility if they are in tamponade. So the next question that we have to ask ourselves in respiratory emergencies is, when do I intubate and ventilate? So the first indication to intubate your patient is a patient that's going into respiratory fatigue. We've all experienced this. They are the patients that look like they are going to pass out because they are trying so hard to get oxygen. If your patient gets to that point, do them a favor, sedate them, intubate them, and ventilate for them. It may be the thing that saves their life. The other indication is upper airway obstruction. So two major emergency situations that we see quite frequently is brachycephalic airway syndrome and laryngeal paralysis. So these are just inflammation of the airway, typically is not allowing the patient to move air in the appropriate way. And then the third that we see quite frequently is foreign bodies that get stuck in the trachea. Now, these are particularly tricky depending on what gets stuck in the trachea. In some instances, you can sedate these patients enough to look into their oral cavity and see the obstruction. If it is allowing any air to get by and you can't quite grab it, you can intubate these patients with a small ET tube, try to pass it around the obstruction, inflate the cuff, and provide gentle traction to get that obstruction out. In this case, use lots and lots of lube on that tube that you're putting in there. And then the other thing that I've used in these situations is actually a Foley catheter. It's the same idea. You want to pass something around the obstruction, inflate a bulb or a cuff just past the foreign body, and then gentle traction to try to get it out. I always warn the owners that we can tear the trachea in these situations. It could be that we can't get it out, but those would be tips to try if you get yourself into these situations. And always remember that an intubated patient that we're ventilating needs to have a dedicated nurse. So again, a huge time suck and staff suck as well. In
Dr.
the case,
Roden,
yeah, go ahead.
Couple questions.
Yeah.
Any tips for tapping a pleural effusion to avoid causing a pneumothorax?
Yeah, so tapping a pleural effusion and avoiding a pneumothorax. So again, going on that diagram that I showed you guys a few slides back, I'll go back. Try to stay in the ventral portion of the chest. When I tap these guys, what I do with my 18 gauge over the needle catheter is I introduce both the stylet and the catheter itself into the chest. And then once I get a flash of whatever fluid is in there, I introduce just the catheter portion into the chest and I pull the stylet out. So really, there's only ever about maybe 1 to 3 millimeters of the jagged part of the needle going into these patients. I have lacerated lung lobes before using like a needle or using a butterfly catheter. My advice is stay low. Try to point your needle or catheter to stay along the body wall as much as possible. And then if you do feel any suction or any resistance while you're removing the fluid, then stop, redirect, because most of the time what you're up against, if you don't have an ultrasound, most of the time you're actually up against a lung lobe. So that's going to increase your chances of injuring the lung lobes and causing a pneumothorax. If you're using a small catheter, 18, 16 gauge, even heck, like a 12 gauge, that hole that you're making seals over incredibly quickly. And sometimes we'll put like a little triple antibiotic ointment right on top of it just to make ourselves feel a little bit better. But most of the time, the hole that you make isn't going to cause a pneumothorax, but definitely puncturing the lung can. But stay low and stay along the body wall as best as possible. Does that answer it?
Yep, I think so. And
Okay.
I have one other question. Is the dose for lidocaine for VPCs in the pericardiocentesis scenario on the dose sheet?
I would need to double check, but I use 2 mg per kg as my dose across the board for lidocaine with VPCs.
Thank you.
Excellent. All right. I was going the wrong way. All right. So if you do need a patient to be transported, like I said earlier, you can use those disposable canisters, or we are lucky enough in North Carolina to have a few companies that will transport pets. One of them that we use oftentimes is called Pet EMT. The gentleman that runs this service is available pretty much around the clock, and he will drive just about anywhere. The one drawback to Dennis, who runs the service, is that he's way too busy. So if you do have a patient in need of transport with oxygen, he does a great job. All right, so respiratory emergency analysis. Psychologically, I want you guys to remember, take a breath. I also want you to remember that medicating, watching, and waiting is not ignoring your patient. It might be the best thing that you can do for them, because handling them may stress them and kill them. The physical constraints of these types of emergencies, you guys are gonna need an oxygen source and you're gonna need an oxygen delivery system. And hopefully I gave you some tips about how to build something on a budget. Educationally, teach your staff what to watch for. You guys already know how to do this. Also remember to teach your nurses IV catheters can kill, and review these 2 things at a monthly meeting for them. The next thing, financial. I am a big proponent of people charging for what they do and charging for what they use. So these fees here that I've listed are typical fees that would be charged in an emergency setting, depending on your hospital, your location. Oxygen setup fee could be anything from $30 to $110. Oxygen per hour, I've seen it range from 10 to 40. Please, please, please charge for your x-rays, and don't be afraid to tell owners that you may need a radiologist to review them. And then if you do have that ultrasound in your practice, my recommendation would be learn how to use it, and then charge people $70 to $100 every time that you gain information to help their pet. And then insofar as time analysis, there's nothing I can do to save you a whole lot more time besides what we've already discussed, because respiratory emergencies are just very time consuming. So we'll do a little bit more audience participation. So this is Lola. She's a 10-year-old female spayed golden. She presents for collapsing. Brief physical exam parameters, you find that she has pale mucous membranes, heart rate of 180, and a distended abdomen with a fluid wave. So I want to hear from you guys. What are your differentials?
We have hemoabdomen, hemangiosarcoma, splenic rupture,
Love it.
hemo.
Anything
hemangio.
else? Anything
No,
else?
no, got a theme going here.
All right. So a couple other differentials, because as an ER doctor, we get into only picking one or two differentials. Did you have more, Paige?
Yeah, we have one heart, and now heart failures are starting to roll in.
Love it. Yes, absolutely. Uroabdomen is another good one. Though usually they don't just collapse. Usually they're hit by a car first, but put it on your list. All right. So we know that this patient has some sort of disease that's causing her to be in shock. So what do you do next? You don't have an ultrasound. The closest ER is an hour away, and you can't just put her in the car and make them drive for an hour. So here's poll number 2. What do you do next? Do you do abdominal x-rays, blind abdominocentesis, place an IV catheter and start fluids, or recommend euthanasia? Excellent. I think that all of those are great options, and I wouldn't fault anybody for recommending euthanasia, especially if you know these clients, know this dog, know that she may have had a tumor in her abdomen that they were, not planning on treating in any sort of fashion. So I think that all of these are very reasonable next steps for this patient. So because I am who I am, I'm curious about what is going on in that abdomen. I don't have an ultrasound, and I know there's a fluid wave, so I'm probably going to choose a blind abdominocentesis. Let me see if I can. So to do a blind abdominocentesis, again, this is one of those procedures that is pretty scary the first probably 10 or 12 times that you do it. But once you get the hang of it and get some comfort around the fact that you can't make things a whole lot worse, then you're going to be a little bit more comfortable with it. So the landmarks for this is that I first lay the patient in lateral recumbency, right or left. Doesn't usually matter if you have a pretty good fluid wave. And then I find their umbilicus and I put a cross mark on them in my imagination and essentially give them 4 quadrants. So the cranial quadrants, I know that the liver is up there, and maybe this patient is in liver failure, maybe he's got a big liver, maybe he's in heart failure. I don't know if I want to go in that region. The liver really doesn't move out of the way when you poke it. The spleen is also in the upper left to mid abdomen, so maybe not going there. The bladder tends to move itself out of the way when you poke it, if it has fluid around it, and so do intestines. So I tend to go in the caudal abdomen, usually whatever side is most dependent. And so I don't go right on the umbilicus. I usually measure about 2 to 3 finger widths caudal, and then 2 to 3 finger widths ventral. If you have an ultrasound, find yourself a pocket and poke. But in this case, or this picture on the right, you see a patient in that position, and they have used sterile gloves, prepped the skin, and then have someone with a syringe pulling out whatever fluid is in there. So in this case, we have blood. So you get blood from the abdomen. The next question is, well, now what do we do? So I want you to ask yourselves 2 questions. The first question is, does it clot? If the blood that you get in this syringe clots, congratulations, you hit a vessel or an organ. Don't freak out, because the small needle that you used is probably no different than taking a fine needle aspirate or venipuncture. You probably didn't cause any more harm to this patient. If the fluid doesn't clot, this indicates that it's free fluid from within the abdomen. And then you can move on to the next question, which is, what is the PCV total solid? This is important because it helps us to know essentially, how much should I be freaked out right now? And it also helps you to kind of gauge how quickly you need to get things going for your patient. So our general rule of thumb is, if the abdominal PCV is less than the peripheral PCV, we tend to put it in the category of a small bleed or a slow bleed. Now, keep in mind, small or slow bleed can turn into something more massive very quickly. If your abdominal PCV is greater than or equal to your peripheral PCV, or closely approaching it, then you probably are dealing with something that's more of an active bleed or a massive bleed. And this indicates that you should probably get things rolling a lot faster for this patient if your owners are in fact going to go forward with treatment. So just to recap, very common causes of hemoabdomens, and there's more, but common causes of hemoabdomens are bleeding mass, hemangiosarcoma being our number one favorite, especially for Goldens, trauma, and coagulopathy. Usually within a few minutes of talking to the owners, you're going to gauge, have they been in any sort of traumatic event? And then by looking at your patient, seeing things like ecchymoses, petechia, difficulty breathing and maybe having fluid in the chest, or having melena, might tell you that this patient has a coagulopathy. A bleeding mass, those tend to be older patients, specifically large breed patients, but don't be fooled if you have a Yorkie that has a hemoabdomen. They absolutely can get tumors in their abdomen just like any other breed. So you know you have a hemoabdomen and you need to start resuscitating these patients. So the first thing that this patient needs is volume. They've lost volume into their abdomen and you need to replace it into their vessels. So I use a technique called low volume resuscitation for these patients. So we want to give them a small amount of fluids or a larger amount of fluids, but kind of slowly. The theory behind this is if you give a large bolus quickly, any clots that they may have may get dislodged by you increasing their blood pressure. So what we typically recommend is hypertonic saline. So this is something cheap that you should be able to keep on the shelves in your hospital. And 2 to 5 mils per kilo of hypertonic saline as a bolus over about 1 to 5 minutes, depending how shocky they are. I typically will check the sodium after 1 to 2 doses of this to make sure that they're not getting hypernatremic. And then you can follow this, or if you don't have hypertonic, you can start with just some LRS or whatever crystalloid you have on your shelf as a 10 mil per kilo, what I call slowless. So again, we don't want this volume to go into them super fast because any clots they may be developing could be dislodged. The second thing these patients need is oxygenation. So you can have flow by oxygen going to them, but they have lost cells. They've lost red blood cells and the ability to oxygenate. So many of these patients will rebound a little bit with your IV fluids, but many of them will also need a blood transfusion. So if you're lucky enough to have blood in your hospital, which many people are not, if you have your own donor program or if you have a routine shipment of blood, that's phenomenal. But many times we don't. And so I did put some options here for blood transfusions. I want to take a moment before we chat about that to talk about blood typing. So if this patient has never had a blood transfusion before and is going to be getting a blood transfusion, you typically don't need to blood type them if they are a dog. In a cat, always, always, always blood type, and always know that having cat blood on hand is very difficult to do. So we're going to stick with dogs for a moment. So in dogs, there's DEA positive dogs and DEA negative dogs. If you have donor blood in your fridge, I hope that it is negative because that will be the safest blood to use without testing. Now, if this is a patient that for whatever reason has gotten multiple or even just one transfusion over its lifetime, it is safest to test them and then use a negative donor if possible. Now, going on to the blood transfusion types and how we do it. So if you have whole blood, great. The typical dose is between 10 to 20 mils per kilo for your patient. Packed red cells, half that volume, 5 to 10 mils per kilo. And then the general rule of thumb with packed red cells is that 1 milliliter per kilogram should, in theory, increase your PCV by 1%. It doesn't always happen that way, but that's the theory behind why we use 5 to 10 mils per kilo. And then if you don't have whole blood and you don't have packed red cells in your hospital, an auto transfusion is something that you can do. And 10 to 20 mils per kilo is the dose for that as well. People always ask, how fast can I give a blood transfusion? And the answer is typically, we like to give transfusions over 3 to 4 hours. However, I have given whole blood, whole volume transfusions to small critters like an anemic kitten in a matter of about 5 minutes. So it's not ideal, but if your patient needs it fast, then your patient may get it faster than 4 hours. So just to give you guys a little bit of research behind auto transfusions. So veterinary medicine doesn't have any great research on this, but human medicine had a study published in 2019 in the journal Medicine, where they looked at survival analysis of intraoperative blood salvage from patients with malignant diseases. So what they did is they had over 4,000 human patients, and about half of them got blood during the procedure from a donor, and then half of them got cells that were salvaged from their own body. So a hemoabdomen that they pulled the blood out and then gave it back to the patient. What they found over these 4,000 patients is that blood salvage did not increase tumor recurrence rate, and they followed these patients out for 5 years. And there were comparable survival outcomes for donor blood transfusions and for patients who got an auto transfusion. So the takeaway from this is that as far as we have any information in humans, it seems to be a good alternative if you don't have blood products. Now, in human medicine, they have these really cool guns that you slurp up the blood, put it into a bag, and then you give it back to your patient. So it looks really easy. And in fact, in veterinary medicine, it's similar, but we don't have that cool gun. So what we do have is that abdominocentesis that we talked about. Again, do it sterilely, and then have someone on the other end with a syringe and 3-way stopcock pulling the blood out of the abdomen. What you're going to do is over here in this right picture, they've got the 3-way stopcock blood coming from the patient, going into the syringe, and then going through this line up into a blood bag. Now, you don't necessarily have to have blood bags in your hospital, though you can purchase them. This next slide shows a couple of the different kits that are available. So this kit comes sort of pre-populated with a needle, 3-way stopcock, syringe, tubing that goes into this animal blood resource bag. This is a bag that you would have to spike on your own using one of your drip set, essentially, from IV fluids. But if you don't have those bags that are shown on the left, you can empty out a bag of whatever crystalloid fluids you have laying around, keep it as sterile as possible, spike it, and then use that to collect your blood. I did put the website in here for one of the many companies that does sell these blood bags that you can get. The next thing is, how do we administer this to our patients? We want to make sure that anytime we're giving a blood transfusion, whether it's from a donor or from the patient itself, that we filter it out. Now, we won't talk a whole lot about cat transfusions, but if you are giving a cat a transfusion, these are the filters that are recommended. So these are called hemonate filters. They are very small. filtration, and they will damage dog blood. So if you have these in your hospital, only use them for cat blood transfusion. You can also use them for albumin transfusions if you're doing that, or plasma. These shown on the right are the inline filters with 170 to 260 micron filters. And these are more appropriate for dog blood cells. So these are what we call inline filters. So you're going to have your bag hanging dorsally. It's going to drip into this filter, and then gravity dependent will drip into your patient. We don't recommend using infusion pumps because many of the pumps can actually damage the cells that are going through these lines. All right, so to recap our hemoabdomen analysis, again, psychologically, take a breath. You've got this. Your patients need volume and oxygenation. So 2 easy things to remember. And give yourself a pat on the back. You know what you're doing. Pull up your britches. You've got this. Physically, what you need in your hospital. You need some fluids. I recommend that every hospital have a bottle of hypertonic saline hanging around for low volume resuscitation. It's also really great for traumatic brain injuries or high intracranial pressure. So it's good to have around, and it's pretty cheap. And then ideally you would have a collection kit and a filter as well. And then the education. So this part, again, we've already talked about how to do a blind abdominocentesis. It's pretty easy once you get past that initial worry that you're going to injure something. And then you need to know how to use a 3-way stopcock and teach your nurses how to do this as well. We all know that it's not as easy as it should be. And then the other piece of education is to always use a filter. Now, I have had practitioners ask me, what if I don't have a filter? Can I just give this, auto transfusion back to the patient? And the answer is, if you think that you need to, sure, you could. You also need to know that you're running the risk of giving them any clots that may be in there, any fibrin that may be in there, and it is probably increasing their risk of further complications. So back to the analysis. Financially, so these blood collection kits and filters, the whole set can be purchased from $20 to $60 on the low end. You can pay upwards of $400 or $500 per kit if you really want to. I recommend not doing that. And a typical cost for a blood transfusion in a hospital is $300 to $800 per unit. And you can charge for giving the patient back its own blood. You've spent a lot of time, energy, and effort to do this. So we're going to move on off of hemoabdomens onto this next.
I have a couple questions before you move on.
Yeah. Go ahead.
One question is, do we need to alter I think you might have answered this, but do we need to alter the fluid from the abdomen in any way before an auto transfusion?
That's a great question. So the answer is no, you don't need to, except for a filter. The one indication that might be different is if you have a trauma. So if you have a trauma and you don't think the patient has a bladder, the risk you run is that the bladder may have ruptured, and the patient, if you give them that blood, it may also have urine in it. So in trauma patients, I tend to be a little more careful about what I choose. Luckily at State, I can test, does this blood have a high level of potassium in it? The other thing that you can do as sort of a cheat is if you have an azo stick, it's not perfect, but if you have an azo stick, you can drop the blood from the hemoabdomen on there. And if it has a high azo reading, it probably also has some urine in it. So I would be a little bit careful about that situation and would opt not to give them that blood if possible. The other thing that I sometimes do in trauma is check to see if there's bacteria in it, because sometimes these patients have ruptured GI tracts. So those would be things to maybe check for, but otherwise you don't need to alter it at all. Good question.
Going back to respiratory.
Yeah.
You're talking about how IV catheters can kill, or do you mean that because the animal is too stressed?
Yes, absolutely. So that's a great question. So IV catheters can kill if you are bound and determined to get IV access and you're stressing your patient out too much. That is where I have actually been the culprit, and my nurses have been the culprit of killing patients, because I'm bound and determined to get an IV catheter in. My recommendation is to give these patients a lot of time. The worst thing you can do is put an IV catheter in a stressed out patient because they're already on the precipice. That's what I mean by IV catheters can kill.
Thank you.
Yep.
Now on to poll
number 3. All right, what's your diagnosis? Excellent. Excellent. There may be a little bit of food in there too. I do see some ingesta, but excellent. You guys all got it. This is a GDV. This is one of the scarier emergencies for me because I don't do it often. So we're going to keep it kind of simple. You guys probably do more of these than I do, but my recommendation is 2 forelimb catheters, never a pelvic limb catheter, because this giant gas-filled stomach is actually probably compressing the vena cava and not allowing blood return from the caudal abdomen. So 2 front leg catheters to provide volume to that heart. And then I start with a 20 ml per kilo bolus of IV fluids. To keep this simple, if it's a medium-sized dog, I start with no less than 500 mils. And if it's a giant dog, I just give them a liter. After that resuscitation bolus, I start them on about a 40 ml per kilo per day LRS maintenance rate. If they have improved after that bolus. Now, with these guys, you have to remember to have somebody there to check their heart rate again, check their respiratory rate, check, their mucous membrane colors. You're going to have a very dynamic patient in front of you. So giving 1 bolus, that'll help for maybe 10, 15 minutes, but then they're going to get worse again. So the next thing I do is give these guys some opioid pain meds. Typically, I will choose something like fentanyl, but buprenorphine, hydro, these are all great options. I like fentanyl because I can titrate it, but if you guys don't have that, that's okay. Then the next thing is to decompress that stomach if possible. So an oral gastric tube or trocherization are great ways to decompress the stomach. And I have found over the years that if you have a nasogastric tube, that may actually pass a little bit easier than those oral gastric tubes. I've found that in many cases, trying to pass an oral gastric tube, the patient's maybe not sedate enough, the tube is too big, that pylorus is just like, or not pylorus, sorry, the esophageal junction, it is just twisted so tight that you're not getting that orogastric tube in there. And I don't recommend shoving and pushing too hard because you can actually rupture the stomach internally. Now, if you can't get an orogastric tube in and you don't have a nasogastric tube, by all means, trocherization is the way to go. So how do you trocherize? Well, you lay the patient in lateral recumbency and you start thumping around on their abdomen like it's a drum. Where it sounds like a drum, that's going to be the place with the most air. Most of the time, you're not going to have a spleen in the way if it sounds like a drum. So again, this is where your large bore over the needle catheter comes in really handy, or just an 18 gauge needle. And you literally just shave a patch, do a little scrub, and poke that needle into the abdomen. It is going to smell really bad, and you may actually get some stomach material gurgling and bubbling through that catheter. That's okay. Remember that most of the stomach contents is fairly sterile because of the pH in the stomach. So this next study was from veterinary medicine, and the Journal of Small Animal Practice in 2013 had a study where they compared gastric decompression with an oral gastric tube versus trocherization. What they found is there was no statistical difference between the 2 methods for survival to discharge. So whether you decompress with an oral gastric tube or a trocar, didn't matter, survival rates were the same. They also did state that either technique is with low complication and usually high success rate. So whatever is most convenient for you to decompress the stomach is ideal. So now we need to talk a little bit about what are some of the poor prognostic indicators for GDVs. So if your patient has peritonitis, coagulopathy, or DIC anytime during their stay, hypotension anytime during their stay, even on admission, gastric wall necrosis with especially with a resection and splenectomy, those are going to be a more poor prognosis than with a patient that doesn't have these things. The last thing here, we're going to go over a little bit more. Failure to clear your lactate during resuscitation is also a poor prognostic indicator. So, Dr. Roden, what the hell does it mean to clear your lactate? Well, many of you have glucometers in your practice, but you may not be familiar with a lactometer. I know I wasn't. When I was in general practice, we didn't have one, but I love having this thing. So a lactometer will help you to read a patient's lactate. And a lactate is a reference that we use to figure out how well is my patient perfusing. So if you recall back to Physiology 101, lactate is the acid, or lactic acid is a buildup when your patient is not perfusing or oxygenating properly. So what we use this for is to guide our therapies of how well is this patient being resuscitated and how responsive are they to my resuscitation efforts. So when we're doing lactate clearance math, the calculation is here at the bottom. You may want to jot it down, take a screenshot, whatever, but it is your initial lactate. So when they first come in, minus the lactate after you've done some resuscitation, divided by your initial lactate times 100 to get your percent clearance. So example one, a patient with an initial lactate of 5, you do some resuscitation, you give the dog some fluids, maybe some pain meds, you trocarize the stomach, and it comes down to 4. So you do your math, 5 minus 4, divide by 5, times 100, that's 20%. That's not that great. You remember, anything less than 40% lactate clearance is a poor prognostic indicator. Example 2, the initial lactate is 12. People see a lactate of 12 and they freak out, as you should. It means things are pretty bad. However, you resuscitate this patient with all of the fluids, you trocarize the stomach, and it comes down to 4. So 12 minus 4 divided by 12 times 100, 67% clearance of that lactate. So what I can say is patient number 2 actually has a better prognosis than patient number 1, despite having that terrifyingly high lactate level on intake. Now, these machines, they're fairly cheap. So $150 for a refurb unit, up to $300 per unit. And then test strips are approximately $1 to $2 per strip. Typically, I see hospitals charging clients anywhere from $20 to $30 per lactate check. And the reason we're doing that is because you're not just using the machine to get a number, you're using it to actually help prognosticate how well this patient's going to do. This is also useful for many patients who have any other form of shock. All right, little GDV analysis. Again, psychologically, take a breath, believe in yourself. You guys manage way more GDVs than I do. And if I can do it, trust me, you can do it. The physical needs in the hospital, IV catheter, fluids, and letting the owners know from there kind of what their expectations will be. Educational portion of this is now you guys know the negative prognostic indicators, and you can tell your owners this when you've started the process of stabilizing their patient. Teach your nurses what to do in these cases. I've worked with a lot of nurses over the years that know, hey, this is a GDV. Let's put 2 front leg catheters in, get big ones in, get fluids going. That's excellent. And now you guys know that you can use a trocar or a tube to decompress that stomach. Again, lactate meters, fairly cheap, and you can charge $20 to $30 per lactate for these patients. Again, very time consuming, nothing I can do about that. I'm sorry. All right, moving on. So poll number 4, when do seizures become an emergency? And I apologize for the way that this is written. I realize that I am a academician by the way I wrote this. So 3 seizures in a 24-hour period, seizures lasting more than 5 minutes, A or B, or seizures, every seizure is an emergency. I'll give you some time for that. Excellent, excellent. So I agree with you guys, A and B. So 3 or more seizures in a 24-hour period and seizures lasting more than 5 minutes. So the reason that 3 seizures or more in a 24-hour period becomes an emergency is because that typically indicates that the patient is going to continue having seizures, and medications are either needed for a patient who's never had seizures before, or if they are a seizure patient, they need to have their medications adjusted. And then seizures lasting more than 5 minutes can and will increase the body temperature for these patients, and they are at a higher risk of internal organ damage secondary to essentially heat stroke. For anybody who said every seizure is an emergency, it may seem like that in the moment. Remind yourself that from what we know in human medicine, seizures themselves are not painful. They are incredibly terrifying to watch, especially if a cat is seizing or a large dog, but the seizure itself is not painful to the patient. Most of the time, they don't remember it in human medicine, or if they do, there's really nothing to remember except that they had a convulsion. Where it becomes an emergency is if they start hitting their head on things, passing out, falling downstairs, things like that. All right, moving along. So in this part, I just want to give you guys a recap of sort of first, second, and third line anticonvulsants. So my first line of anticonvulsants or fast-acting anticonvulsants are going to be diazepam and midazolam. Many practices will have one or the other in their hospital, and they're both fantastic drugs. The doses are there. Both of these drugs can be given intravenously, intranasally. I didn't put it for midazolam, but it can also be given rectally. Typically, the rectal dose is about twice what the IV dose is. Now, if you have a patient that you've given midazolam to, and then they seize again, and you give another dose of midazolam, usually I give them a 3-strike rule, and I say, you've seized 3 times in the last 24 hours, or maybe 3 times in my hospital, you are getting a CRI, or constant rate infusion. If you only have diazepam, it's probably not going to work for more than about 30 minutes. The reason is that diazepam will actually stick to the inside of your plastic syringes, and it won't get to the patient. Midazolam is a better choice for CRIs, and the dose is 0.2 to 0.5 mg per kg per hour to run these guys on a CRI. Now, if you choose to run them on a CRI, you're probably going to need to get them overnight care, because we do recommend usually 12 to 24 hours on that CRI, adjust their dose, or start them on new anticonvulsant therapy, and then taper them off of that midazolam. Otherwise, they tend to continue seizing. Now, the possible complications with both of these drugs are exactly what we want to happen, which is CNS depression, but it also comes with respiratory depression and potentially hypotension. So make sure you're monitoring your patients if you are giving these 2 drugs. Next, for maintenance, the 2 drugs that I go to in emergency settings are phenobarbital and Keppra. So phenobarbital is the old gold standard. It works, and that's why we love this drug. It's also cheap and it's fairly accessible. So typically for a patient who's newly diagnosed with seizures, if I choose to use phenobarbital, I will load them with 3 to 4 mg per kg IV every 2 to 4 hours for a total of 4 doses. I want them to have 16 mg per kg total as a loading dose. You can give 16 milligrams per kilogram once IV. However, I did this once and I regretted it for the following 24 hours because I had to sit with my patient while we intubated them and ventilated them. So it can and will cause profound sedation in many patients. So just be careful if you're giving that large dose. Now, Keppra is a newer drug on the scene, and it comes in 2 formulations. So it comes in a normal Keppra release, which is an every 8-hour drug, or it comes as extended release in the oral formulation. So for IV formulation of this drug, we usually recommend 30 to 60 milligrams per kilogram to load them. If your patient stops seizing after 1 dose of midazolam and they're eating and you don't have IV Keppra, you can absolutely give oral Keppra, or if you have an NG tube in them for some reason, you can give it through the NG tube. You can also, in emergency situations, give Keppra rectally. So if you have a patient who's not doing well, you have them on a midazolam CRI, and they continue to seize through that midazolam CRI, you could try a dose of rectal Keppra or IV Keppra. Or the reason I put this on there is if you are sending a patient to another facility, you could send the owners with the liquid formulation and have them give it as a rectal dose if the dog seizes en route. Now, with the extended release Keppra, this is typically for large dogs, just based on the size and the dosing of the drug. If this tablet is broken or crushed, it loses its efficacy of being every 12 hours. Before you prescribe these drugs, talk to owners and make sure that you're giving the right drug based on their lifestyle. You wouldn't want to give a dog an every 8-hour drug if owners are only going to be able to give it every 12 hours. So the next one is, this is the end of the line anticonvulsants for me. So we've all seen that patient that comes in seizing and you try absolutely everything. You put them on a midazolam CR, you load them on Keppra, or you adjust their Keppra dose, or you adjust their phenobarb dose, and they just won't stop seizing. I've had these situations where owners say, I can't go to the specialty clinic. What else can we do? Through years of working for a neurologist, I found that you can use a drug called clorazepate. It's not commonly used in veterinary medicine, but you can have it scripted out through your local human pharmacy, and it's fairly cheap. Here's the dosing here for this drug. It will cause CNS depression. It will cause respiratory depression. These patients will sleep for like days, potentially, if you give this drug, and that's the goal. The trouble becomes that they may need to be intubated. So the contraindications for this drug are closed angle glaucoma or severe liver disease. So again, end of the line drug. I hope you never have to use it, but if you do, you can reference back to this talk. And then propofol, if you can't get the patient to stop seizing with midazolam, you could try a propofol CRI. This is, again, not ideal. You have to have a dedicated nurse. You have to intubate these patients usually. And then you have to figure out, how am I going to keep this patient from seizing for a long period of time while I transport them to a 24-hour facility? All right. Oh, this should say seizure analysis. Take a breath, try to stop the seizures. Keep these drugs on hand, and you should be able to stop most seizures. Teach your owners what constitutes a seizure emergency. You don't want them calling you for every single seizure, but you don't want them letting their dog seize for 10, 20, 30 minutes. Financial, this should be zero additional cost to your hospital. You probably already have all these drugs. And again, these can be very time consuming. All right, next poll. Do you have a crash cart or crash box in your hospital? I love seeing these results. I'm so happy and proud of you guys that have them. If you don't have them, well, I'm going to teach you something very quick that will hopefully help your hospital. All right, next is, who should know where the crash cart or crash box is? Only doctors, doctors and nurses, or all of your staff? Excellent. Yep, absolutely. All of your staff should know where this crash box is, and know where they can find it at all times. All right. Next, where should the crash cart or box be located? A, in the surgery room, secured to the wall. B, somewhere where all team members can easily find it and they could move it to where it's needed. Or C, in the back storage closet somewhere. Excellent. You guys are amazing. So absolutely, this should be in a place where everybody knows where it is and it should be mobile. So I introduced to you the oh shit kit because sometimes shit happens outside of the main treatment area. Most of you guys are going to have some sort of crash cart, and it's usually in the surgery suite, or maybe it's in the main treatment area. But I have been to some of your facilities and they are ginormous. Okay. So I don't want to be the doctor who has to run from one end of the hospital to the other end of the boarding facility for an emergency that somebody called me about over the intercom. I just don't want to do that. And so an oh shit kit is going to keep you from dragging patients across the hospital to the drugs, and it's going to make it so that you can take the drugs to the patient. So what should I keep in my oh shit kit? And you guys should definitely call it this in your hospital. It will boost morale. So the first thing you should keep in your drug kit, your oh shit kit, is drugs for respiratory, cardiac, or anesthetic related emergencies. So at minimum, atropine, epinephrine, naloxone. Second line, I do think these are important, but some hospitals don't carry them. Flumazenil and atipamezole. And then third line would be lidocaine and Dopram. I frankly have only used Dopram one time in my 10 years of practicing, and I don't necessarily think you have to have it. I do recommend having several syringes and needles, some IV catheters, and then some tape to place your catheters. Emergency drug dosing chart is very nice because some of these patients, you're not going to know how much they weigh, especially if something's happening in the parking lot for a patient you've never seen. But you can guesstimate their weight and you can guesstimate a dose. And then I do recommend putting a few endotracheal tubes in there. You're not going to have one for every size of patient, but a large, medium, small one will get you quite a ways. This is just the example of my oh shit kit that I use when I have patients going down to radiology for a CT or for chest x-rays, when I sedate a patient for an orthopedic exam. Even if they are a stable, healthy dog, I typically take this thing with me because I'm an emergency doctor and I'm always a little bit nervous. So this is just an example of what one of mine looks like. This is my recommendation for your oh shit kit 2.0. So I strongly recommend that you guys look into the Recover Initiative and have everyone in your practice, whether they answer the phones, whether they clean the floors, whether they walk dogs, whether they're a veterinary nurse with an RVT and a specialty, whether they're a doctor, to go through the Recover Initiative CPR course. Even if you don't go through the course, you can download their app, and this app helps to essentially walk you through CPR with telling you how fast to do compressions, when to breathe for the patient, things like that. I also recommend that every hospital, somewhere in the hospital, have the emergency drug chart posted because, like I said, shit happens and it might not happen in the treatment area. So the oh shit kit analysis, take a deep breath, find the kit. This is going to improve your patient outcome. The physical constraints of this is it takes up a very small space in your clinic. So the educational piece is that you need to teach your staff where the kit lives and teach it to them when they're hired, and then show them again every month at the meeting, make sure they can find it. The box itself is pretty cheap. The drugs and the other things in there are where you're going to have a little bit of expense. ET tubes are typically fairly cheap. You already have catheters, needles, and syringes in your hospital. Now the time constraint. So it takes about an hour to create this, 1 to 5 minutes to introduce it. And then I recommend 5 to 10 minutes per month turning over supplies. So if you have 2 bottles of epinephrine in your hospital, keep the unopened one in the oh shit kit. And then when you're out in the treatment area, if you need a new bottle, grab that one from your oh shit kit. If you get a new one that comes in with your next order, put that one in your oh shit kit. That way you're turning over your supplies and not going to have a lot of expired things popping up. So I want to share with you before we close a few of my favorite things. This book on the left by Mike Willard and Harold T. This is the book that has gotten me through practice this far. This book has all of your clinical references to blood work and differential lists for practically every change that you could hope to see on blood work. These two books in the middle are books that I think are pretty accessible to everybody insofar as the type of medicine that they cover. Now, if you want to take a deep dive into emergency and critical care, the Silverstein and Hopper book, also known as the Critical Care Bible, is something that you could obtain. But for a general practitioner, I think there's a lot of stuff in there that you will never use. I am a member of the Veterinary Emergency and Critical Care Society. I do recommend that if you have any interest in learning emergency medicine, that you go to one of their meetings. They do a spring and a fall symposium. Typically, the spring ones are in a really fun and usually tropical location. I also recommend YouTube. Yes, your university professor is recommending YouTube. I watch YouTube videos all the time if I need a refresher on how to do a procedure. I recently did a PIO spay, which I hadn't done in 3 years. And yes, I went in the bathroom and I watched a YouTube video just to make sure I had my anatomy right. So no shame in that. Just make sure you're using good sources. Next is, this is vetfast.com. It's just one of the many resources that are available to learn how to use that ultrasound to do a point of care ultrasound for your patients. And then if you don't know what to do next, phone a friend. We always have somebody available in the ER, whether it's a intern or resident who has access to an after hours senior clinician, or senior clinicians themselves, usually during the daytime. We're available for phone consults. If we can't take your patient in at our hospital, we'll be able to tell you where they could go or tell you what to do next in your current situation. And then what should I tell my clients to do when I'm not open? Well, the good news is Vets Pets has so many hospitals that are open now after hours, around the clock, and they provide amazing medicine. So no matter what part of the state you are in, Vets Pets probably has a hospital that's fairly close. So recommend calling one of those guys or whatever emergency is in your local area. Again, you can always have your clients call NC State and we can help to try to direct them to the nearest hospital as well. One more resource that has become available is a company called PetVice. This is one of just many companies that is trying to provide for clients a way to speak with a veterinary professional that can help guide them to let them know whatever's going on with your patient or your pet might require general practice level care, urgent care, or get your butt to an emergency right now. So this one is run by one of my technicians at State. It's fairly new, but what she does is a video conference call and she talks to the owners, gets some information about what's going on with the pet, guides them as best as she can to which type of hospital she needs. And because she is at NC State, she does have a pretty good network of hospitals, which she's able to then call the hospital, match a patient up with the hospital, and then get them a space reserved, which is important. So that is just something that's become available as of recent. So again, thank you guys for showing up tonight. I am so happy that you all spent your evening with me. Here's my email address. If you guys have any questions, feel free to email me. If I don't respond to your email, hit me again, because I get about 100 emails a day working at NC State. And then thank you, Vets Pets, and thank you, Paige and Matt, for helping make this all possible. So we'll open it up for questions if you guys have any.
Well, thank you so much. And I will echo what was already in the comments here, which is this is a really nice practical review and some new tools. Thank you for the CE. Someone put in a funny comment when you're going over the seizures was clorazepate, the cluster buster.
Yes. Yes, that's amazing.
And then someone asked, is the Recover Initiative veterinary specific?
Yes, it is, to my knowledge. If you want human CPR, I think it's the American Red Cross.
Many thank yous and great info. This is great presentation. This is awesome. which I agree with. And again, for those that are still here, we will be emailing out a very extensive and concise drug sheet, your CE certificate, and some copies of the slides as well.
Well, thank you guys all again for coming. I really do appreciate it. And again, please email me if you have any questions. All right, Frank. And here's my friend Frank. He wanted to join the whole time. Yeah, you don't want to join now. All right.
All right.
Have a good night.
Thank you, Dr. Roden. Thank you, everybody, for joining. See you
Thanks,
next time.
guys.